Dr. Peter Angelos. Peter is a faculty scholar at the Bucksbaum Institute, is the chief of endocrine surgery here at the university. Peter's written broadly on issues in surgical practice, on teaching surgical residents, as well as technical questions about endocrine surgery. A year or so ago, Peter was recognized by physician colleagues here at the university with the Peer Role Model Award for professionalism in patient care. Today, Peter is going to speak to us on the topic of redefining the art of surgery, the surgeon-patient relationship, and the future of surgery. Peter.
Okay, thank you very much. It's a real pleasure for me to be here with you, and we're going to go back to the beginning here. It really is. It's an honor, and I have to acknowledge the fact that it's after lunch, and I think you're all getting a little tired. And it was a very good lunch, by the way, so thank you. But I have a short time, and I want to keep you awake, so I'm going to try to move rather quickly in the hopes that most of you won't fall asleep. You'll see that I have a slightly different approach than Peter Ubel, in the sense that I'm going to perhaps just take a different way of looking at the surgeon-patient relationship. And so the big picture is I want to essentially do four things. I want to talk about why this is worth exploring. I want to spend a little bit of time talking about where we have come from, because I do think that informs how we deal with the things as they are. I want to just spend a few minutes talking about the contemporary views of the surgeon-patient relationship, and then finally talk a little bit about what the future might hold. And so why examine the surgeon-patient relationship? Well, I think that there's no question that surgery requires the potential to harm a patient significantly in order to heal them. And so in that sense, I do believe that the surgeon-patient relationship, although not different in kind from other doctor-patient relationships, does have some nuances that are worth attending to. So that's the first thing. Secondly, as a surgeon, we regularly do things to people that outside of the context of the operating room would be illegal. And that is, it's to be expected. Now, I'm an endocrine surgeon, so what I do on a regular basis is cut people's throats. And so, that's not the sort of thing you would generally do. But in the context of the surgeon-patient relationship, it works. It makes sense. And so I think we need to spend a little bit of time thinking about that. And then, again, I can't really go into a lot of detail on all these things, but certainly surgery is a different type of relationship. And so the relationship that I have with my patient is not going to last for decades in most circumstances. Occasionally it does. Most of the time it's not. It's relatively focused and rather episodic. A few preoperative visits, maybe a few postoperative visits. But I don't get to know my patients for decades the way someone like Mark Siegler does. So what do I get to know about them? Well, I do know, it is an intensely physical relationship in the sense that I have seen aspects of them that they have never seen. For example, I know what their thyroid looks like. Now, that may not matter to you, but for some patients, that's a very significant thing. And it's interesting the number of patients who say, could you take a picture of it? Could you take a picture of what you take out? And it struck me that it's sort of a fundamental question patients have. Well, you get to see it. How come I don't get to see it? And I do think that, responding to that and saying, sure, we all have smartphones now. We can take a picture of it. We can email it to them. We can text it to them. It's sort of surprising to me, but patients really like that. And so we try to make them happy. Now, finally, I do think that consent for surgery, and we've talked a lot about consent and how valuable it is, how communication depends, consent depends on communication. But I would suggest to you that often we think about informed consent, especially informed consent for surgery, as looking at risks, benefits, and alternatives and communicating those to patients. And I would suggest that that is important, but that is an insufficient view of the surgeon-patient relationship. And so in fact, I would say that this sort of checklist idea about informed consent misses the essential trust that is necessary. And so it is, I believe, absolutely critical that whether the patient can remember all the things that I told them about the risks, benefits, and alternatives, they need to trust me to operate on them. And whether they understand it all, whether they remember it all, I think is important, but less important than if they trust me. And perhaps that's difficult to assess, but nevertheless, I think it's very important. Now, I just want to say a couple words about responsibility in surgeons, and for many of you, this is, you've seen this before, but based on Charles Bosk, Forgive and Remember, an excellent sociological study of surgical residency done here at the University of Chicago. I think most of you are familiar with the study. Bosk said, and I'm going to just quote because I think it's so well stated, and he can say it better than I, when a patient of an internist dies, the natural question his colleagues ask is, what happened? When the patient of a surgeon dies, his colleagues ask, what did you do? By the nature of his craft and his beliefs about it, the surgeon is more accountable than other physicians, and he also has much more to account for. And so I think this is an important thing and does have a significant role in the sort of the way surgeons think about what we do to and for patients. So let's just take a minute and think about where we have come from. So rather than present you a lot of data, I'm going to take a different approach, and that is look at something about the historical view of the relationship between the doctor and the patient. And today is my eldest daughter's birthday. In honor of her and her interest in art history, we're going to talk about art just for a couple minutes. And so this is a very famous painting. Many of you have seen this. It's called The Doctor. And if you look closely, there's some important things. I'm not sure if you see well, but here's the patient, here's the doctor looking concerned, here's presumably the father, the mother with her head down. You know, this is a very powerful scene. What can we say? Lots of things, and people have written papers on this, and I certainly don't have time to do that. But I would suggest to you that from this, we can see the doctor is thoughtful, the doctor is caring, the doctor is concerned by his actions, trustworthy, and someone who is welcomed into the home. And so these are all things that I think have been fundamental in shaping our historical view of the doctor-patient relationship. Now, what about the historical view of the surgeon? Well, I would suggest it's different. So here's a view of early surgery, similar time frame. Okay, it's very different. Now, what are some of the differences? Well, first of all, surgery is brutal. The surgeon is callous to the suffering of the patient. In fact, that was necessary to be a good surgeon at that time. The surgeon is struggling against the patient along with a dozen other people. And surgeons operate in scary places. They go to the operating theater. It's not, or, you know, in the old days it was done in your home, but that was pretty scary too, but that may have been worse. But these days it's not done in it's not done in your living room. It's done in the operating room or the operating theater. So things are different. Now, if you go back, certainly prior to the development of anesthesia, speed was absolutely essential. And I would say there was a time when this concept of the surgeon-patient relationship was relatively irrelevant because you needed to be absolutely fast. And there are lots of historical accounts of how surgeons would do battlefield amputations in 20 seconds. And if you were slower than that, you know, the patient would generally run away from you if he or she could. So speed was essential. Now, after the development of anesthesia, surgeons changed and surgery changed. And again, we can't spend a lot of time, but a few things to suggest, and this is, a beautiful portrait from Eakins, the Agnew Clinic. So the patient's asleep, here's the patient, and the surgeon is sort of, is almost like an artist. It's not the battlefield surgery, it's a different setting. The operation can take as long as necessary, and I think if there are any anesthesiologists here, they would say, and they do take as long as necessary. There's certainly necessity for finesse and meticulous technique, and that was really emphasized to a much greater degree when it wasn't all about speed. Finesse and technique became very, very important. And I think many people assumed that even, with this new development, and there wasn't the struggles with the patient, but the assumption was that still the surgeon-patient relationship was less important because the patient was asleep anyway, and you can't have a conversation with them under general anesthesia. So let's think a little bit about contemporary views of the surgeon-patient relationship. And again, I don't have a lot of time to spend on this, although I would love to. There are a lot of stereotypes about surgeons. And sometimes stereotypes have some basis in reality. And I will leave you to think about what is the sort of reality and what's not. And this is a common sentiment. I don't care if my surgeon's a nice guy. I only care if he or she can cut. Now, I've heard this a lot, and I've actually heard medical students talk about how, well, surgery is, it's not about the relationship, it's all about the technique. But I'm not sure that this is actually accurate, and we'll go on to talk about that. Now, obviously, there are many jokes about surgeons, and if we had more time, I would share with you some of my favorites. But just one that I just cannot resist, and that is, what's the difference between God and a surgeon, right? God knows he's not a surgeon. So I'll let you think about that a little bit. It just takes a minute for that to sink in. So I would suggest to you that today, despite where we've come from, where we are, there are some additional challenges to the contemporary surgeon-patient relationship. Throughout medicine, especially in surgery, there's an increasing emphasis on volumes and RVUs, and surgeons are really sort of pushed to spend less time with patients, see more patients. I think everybody is faced with that to some extent if you're practicing clinical medicine today. The electronic medical record provides an additional potential impediment because it emphasizes the interaction with technology rather than with patients. And so, again, I think that's an issue that we have to attend to. And finally, surgeons get paid primarily to operate and not to talk to patients. So the surgeon-patient relationship, I think, is also affected by the internet. And very briefly, technical ability is necessary for surgery, but not sufficient. And by that, I mean patients today have increasing choice of who to choose as their surgeon. There are rating sites you can go and see how good was your surgeon's bedside manner. And there are patients who talk about their experiences, good or bad. Now, many people see this as a problem. I think that this is a potential opportunity. So what does the future hold? Well, Niels Bohr, famous guy, said prediction is very difficult, especially about the future. And so the good thing about making predictions about the future is nobody comes back and tells you 20 years later you were wrong. So it's really a good thing to do. So I'm going to just suggest a few things. The challenge to be a complete surgeon, and by a complete surgeon I would suggest that is someone who is technically excellent, but also is a great doctor. I would suggest that surgeons today face the challenge of overcoming impediments to the surgeon-patient relationship. They need to engender trust in a short period of time, and success demands that patients become adept at engendering this trust. So these added challenges for today's surgeons, I would say the central questions have changed. It's not just what can we do for the patient, but now it's what should we do for the patient? And this is, again, the value that Peter Ubel talked about. The latter question cannot be answered by the surgeon alone, and it requires this collaborative relationship with the patient. So finally, I would suggest patients increasingly expect their surgeons will display equivalent skill at the bedside as in the operating room. I think surgeons need to accept these new patient expectations as the goal to which they must aspire. And I think the central role of the trust in the surgeon-patient relationship needs to have increasing acknowledgement and encouragement, and that it should be made more part of the informed consent process. And finally, I would suggest that the future of surgery depends on the quality of the relationships between surgeons and patients today. So again, thank you very much for your attention. It's a real honor for me to be here. Mark says I have time for 1 or 2 questions. Yes. Yeah, no, I think that that's really true. And I would suggest to you that, in fact, and with no offense to non-surgeons in the room, you know, lots of internists and cardiologists and, you know, neurologists recommend surgeons. And what do you make that recommendation based on? Well, I guess the best is outcomes, although you don't really know what happens in the operating room. So no, I think that you're right. Peter. I thought you had your hand up. Did you not have your hand up? Was I hallucinating?
Maybe listening to. That I think it's really important not to discuss. What I also worry about is establishing trust. There's a danger of making that trust. Come in very warmly and empathetically, tell them what they need to have done. And so the one thyroid person knows they need to have thyroid not stop, nothing they won't, and they can both be loved and customers on sites that they technically want.
Yeah, I mean, I think that you're right. I don't think there's anything wrong with being warm. I think that that's a good thing. I think that when there is a clear medically beneficial, you know, when there's a right answer medically, I think it's fine to be decisive about that. I think that the challenge that you raise, which is absolutely I have not addressed, and that is when it is not clear what the right thing to do is. And that's where, I mean, I guess I think that trust is, I think we can't downgrade the importance of trust even if we upregulate the importance of discussing options and alternatives. So I would say, yes, I agree with you. Thank you.